Welcome to ACE Training, Alzheimer's Care Education for Acute Care Nurses. During ACE training, you will be provided a brief overview of Alzheimer's disease, including history, risk factors, and prevention. During this training, Alzheimer's disease will be referred to as AD. Clinical presentation, frequently used medications, and therapeutic interventions will be addressed. The NLN acknowledges a worrying gap in nursing education and clinical practice. Dementia-related behaviors have been identified as a significant source of distress for healthcare providers. 1 in 9 people aged 65 and older has Alzheimer's disease. 25% of hospitalized patients aged 65 and older have some form of dementia. The National Plan to Address Alzheimer's Disease was signed in 2013 by the President of the United States. The Purple Ribbon Task Force was adopted by the General Assembly of the state of South Carolina in June 2008. Despite these efforts, still no protocols, policies, or standards of care exist specifically targeting the AD patient in an acute care setting. Alois Alzheimer is credited with first diagnosing AD in 1901. He reported his findings in 1906 after caring for a 51-year-old female, Auguste Dieter. Alzheimer identified 3 unique findings upon autopsy. The cerebral cortex was thinner, the existence of cerebral plaques, and neurofibrillatory tangles, which he identified for the first time. Alzheimer's disease is a progressive degenerative disorder that attacks the brain's nerve cells, or neurons, resulting in loss of memory, thinking, and language skills, and behavioral changes. AD is the most common form of dementia. It is incurable and always fatal. There is no known definitive cause, prevention, or symptom management. 5.3 million Americans currently live with AD. 1 in 9 people aged 65 and older has AD. And 1 in 3 seniors dies with AD or another dementia. Alzheimer's disease is the 6th leading cause of all deaths in the United States and the 5th leading cause of death for individuals aged 65 and older. Every 70 seconds, another person develops AD. Why is ACE training relevant for nurses at McLeod-Loris? South Carolina ranks in the top 10 states for growth in population of individuals 65 years and older. Residents 65 and older comprise 14.7% of the state's population. Horry County is expected to experience the greatest growth of any county at a rate of 1.9% annually. South Carolina tied for 10th place nationally for greatest number of AD-related deaths, a total of 1,570 AD-related deaths, or 33.9 AD deaths per 100,000 people. Currently, the exact etiology of AD is unknown, but thanks to the tremendous push for targeted research over the last 3 decades, the answer is closer than it once was. Most researchers agree the cause is probably multifactorial, including lifestyle and genetics. A heart-healthy lifestyle is generally thought to be a brain-healthy lifestyle as well. Clinical presentation may include some or all of the following behaviors: memory loss that is disruptive to daily life, challenges in planning or solving problems, difficulty completing familiar tasks at home, work, or leisure, confusion with time or place, trouble understanding visual images and spatial relationships, new problems with words and speaking or writing, misplacing things or losing the ability to retrace one's steps, decreased or poor judgment, withdrawal from work or social activities, or changes in mood and personality. There seems to be some correlation between cardiovascular and heart damage and the development of AD. Hypertension, hyperlipidemia, stroke, and diabetes seem to play a role in increasing risk of development. Upon autopsy, research has shown as many as 80% of AD patients had cardiovascular disease. In approximately 1 to 5% of cases, genetics is thought to play a nominal role in AD development. Although AD strikes people in their 30s and 40s, advancing age is still regarded as a primary risk factor. Several studies have proven caffeine to be quite promising in reducing the risk of AD development. Currently, there are no medications to prevent AD. There are only disease modifiers. Some drugs are thought to slow the progression, but none have been proven to halt or reverse the disease process. Some studies have shown significant correlation with head trauma and development of AD later in life. Standard safety precautions, such as wearing seat belts and helmets, may mitigate this risk factor. Decreased ability to communicate does not necessarily mean decreased awareness or understanding. Please understand many patients in this situation are aware and embarrassed by the fact they don't remember simple things. They know they don't know. It can be extremely frustrating for them to be unable to communicate basic thoughts and needs. Reality orientation does not work with this patient population. The use of therapeutic lying is a common practice. You are busy, you are tired, you are frustrated. However, taking an extra moment or two to facilitate communication can save you time and frustration. Memory aids are great tools. Label items such as the bathroom or closets or all exits. Ideally, each floor should have a room or rooms set up for use with these patients. Have permanent signs put on major areas of the room. If this isn't feasible, laminated paper signs can be kept at the nurse's station for reuse. Try to minimize the use of the patient intercom for communication. This can be disorienting and even frightening for some AD patients. Most importantly, maintain a patient, soft tone and manner. AD patients will sense if you are tense or rushed. This will frequently exacerbate their anxiety and escalate the problem. Maintain eye contact, use short, simple sentences, speak slowly, be specific using a pleasant tone. Always repeat your questions the same way. Use yes and no questions and allow ample time for the patient to respond. Sometimes 20 seconds or more is required. The Alzheimer's Association suggests using a why question to get to the root of a problem. For example, why are you concerned about what time it is? Listen to the patient's caregiver or family member. They know the patient better than anyone and can give valuable insight into their current state. Reports of increase in confusion or change in level of consciousness could be indicative of metabolic changes such as glycemic issues or abnormal sodium values. Promote trust by acknowledging painful stimuli or procedures. Apologize for them and attempt to minimize the occurrence. Never talk about the patient as if he or she isn't present. Remember, his or her ability to communicate is not necessarily indicative of his or her ability to understand. Consistent, predictable routines are often comforting and calming. In addition, facilitating continuity of care can minimize anxiety and promote patient trust. Allow patient to use security items such as blankets or pillows from home. Minimize stimulus. This may not be the most appropriate patient to have several nursing or medical students participate in care. Although family and friends are usually well-intentioned, their presence may be upsetting in the acute care setting. Pain management is very important for all patient populations and especially the AD population. Many will be unable to tell you they are in pain and others will not be able to accurately describe the pain. Use your assessment skills to identify nonverbal pain cues and address the issue as possible. Simple things such as additional pillows and frequent repositioning can minimize pain and reduce anxiety. The PAIN-AD scale, or the Pain Assessment in Advanced Dementia scale, can be a useful tool in assessing pain. It is not a perfect method because it relies on observation and not patient reporting. However, it has proven to be a fairly accurate measurement strategy when compared with self-reporting of pain by patients with moderate dementia. As reported by Cotter and Evans in 2012, the use of physical restraints in older adults is associated with poor outcomes. With the exception of extreme circumstance, physical restraints should be avoided. Also, there should be ongoing assessment of the need for invasive treatments such as IV sites, Foley catheters, or NG tubes. Frequently assess the need for toileting and anticipate needs whenever possible. The use of bed exit alarms may help reduce falls and promote patient safety. Utilize sitters whenever possible. Hospital-provided sitters are ideal, but may be cost-prohibitive. Encourage a family member to stay with the patient to assist with ADLs and notify staff when needs arise. AD patients frequently wander. This in and of itself is not necessarily bad. It can be therapeutic and provide exercise if done safely. If a patient does not have to be in bed for treatment or for maintenance of invasive lines, allow them to wander with supervision. This is commonly known as therapeutic wandering. If doors can be closed to provide a continuous loop around a nurse's station or unit, the patient may walk freely. This gives the patient a sense of independence, minimizes anxiety, and prevents patient-nurse frustration. Other fall prevention methods utilized for all patient populations can also be used. Night lights in bathrooms, ambulation devices at bedside, non-skid footwear, keep floors and walkways clear, and communicate the risk status to all staff. The use of a common indicator, such as the small purple Ace of Spades card provided by ACE Training, can be placed on the door of any AD patient's room to indicate increased fall risk. Mr. Winters is an 80-year-old male patient admitted 2 days ago to ICU for AFib and CHF. He has a history of Alzheimer's. On day 3 of his admission, he is to be transferred to the med-surg floor. The ACN is informed during report that the patient sometimes exits the bed, pulls at his IV lines, and is frequently disoriented, especially during morning and early evening hours. This scenario addresses issues with maintaining a therapeutic environment of care. Typically, patients with similar clinical presentations are placed in rooms close to the nurse's station. This may not be the best location, and alternate room placement should be considered on a situational basis. Always make every attempt to ensure there is adequate lighting in the patient's room in order to minimize shadows and reflections during sunrise and sunset. The Alzheimer's Association acknowledges AD patients can become confused by shadows that are prevalent during early morning and evening hours. The shadowy shapes are difficult for them to process and may cause confusion and anxiety. AD patients have an impaired ability to separate reality. Patients with Alzheimer's and other dementias frequently do not do well in high-traffic, noisy environments. These individuals are already in an unfamiliar setting. Placing them in high-traffic areas is not conducive to creating a calm environment which helps mitigate non-therapeutic behaviors. Mr. Smith is a 75-year-old male patient with known AD admitted to the med-surg unit for UTI. He has been admitted for 2 days. During the stay, he has become increasingly agitated. He has removed his IV and pulled his Foley catheter out for the second time this shift. This scenario addresses therapeutic intervention. In this scenario, the ideal course of action would be to notify the MD, discuss the necessity of the IV and Foley catheter. If possible, obtain an order to leave out unless IV access or catheterization become a necessity. Continually reassess the need for any invasive lines such as Foley catheters, IVs, or NG tubes. These can be especially irritating and frustrating to AD patients. Removing these devices as soon as possible may prevent the patient from pulling them and causing additional trauma. When the use of these devices cannot be avoided, camouflage techniques should be utilized. Mrs. White is an 84-year-old female patient admitted 3 days ago for UTI and COPD exacerbation with a history of AD. Each day around 1900, she has attempted to leave the unit as the day shift nurses are leaving to go home. She insists she must get home to prepare dinner for her husband who will be home from work soon. This scenario addresses therapeutic lying. It is generally accepted that reality orientation does not work for this patient population. It seems to only agitate the patient and increase anxiety. An appropriate course of action would be to engage the patient in conversation, inquire about her plans for dinner, and offer to help. Gently guide her back to her room. Prepare to have an activity planned prior to change of shift on the following day to occupy her at that time.